Hey, everybody. Welcome to this week's image critique series. This week, we're going to look at a clavicle series. Clavicles are pretty cool. A lot of times you get a sear fracture in a clavicle. Clavicle fractures are quite routine and they happen quite a bit. So it's important to know what to see on a clavicle x-ray. So hopefully this will be helpful for you. Uh, So we're going to use the same acronym that we have been using, the PACEMAN acronym. Let's go over that real quick in case this is the first one you've caught. The P stands for position. Is there any rotation? Does the positioning look good? Area, do we have the appropriate area involved in the x-ray? Collimation, are we collimated tight or are we collimated open? I'm going to talk about what's necessary there. So, exposure, we're going to see if the exposure factors that were used are proper, and we're able to see sufficient contrast and density of the image. Did we use a marker? Very important. We've talked a lot about that. And A is aesthetics. Does this X-ray look good enough to send over to the doctor? And N stands for name. None of these are going to have any names on them, just for anonymity. We don't want to get in trouble. But yeah, let's get going. We'll use this acronym and we'll talk about the two U's of the clavicle. So for a clavicle series, we're going to do an AP exposure, and then we're going to do an AP axial. It's going to have a 15 to 30 degree cephalic tube angle. Okay, and I'll tell you why when we get to that picture. So here we've got an AP clavicle. It's a pretty nice clavicle. So positioning wise, we look over here to the sternoclavicular joint right here, and there's no overlap in the joint space. There is actually a joint space there. We also look at the AC joint, the acromoclavicular joint, and we have that wide open as well. And that's the easiest way to look for rotation. If you have superimposition of the acromoclavicular joint, they're gonna, you know that you're rotated to the outside or to the lateral side. If you have some superimposition of the sternoclavicular joint, you know that you're rotated medially. Just make sure that patient has their back square against the image receptor and you should be okay. But it's important you know what to look for as far as rotation. Okay. The area, yeah, we're able to see the entire clavicle, which is what we want to see. We want to see the entire clavicle all the way from medial to lateral, and the joint spaces in which they involve. Okay, so area, yeah, we're good. Collimation, you can see the collimation line here. They're on the bottom and the top and the sides. We've collimated very well. So clinically, we should be able to see C5, which is right there. So we could see a little bit more superiorly, but not the end of the world. I wouldn't redo this. Down here, we need to be able to see the entire humeral head, as well as a little bit of the lesser trochanter. So we're actually collimated pretty well. Medially, we need to be able to see the spine, where the clavicle itself articulates with the sternum. Okay. Laterally, we just need to see some skin margin out here. We want to see that deltoid muscle coming down right there. Okay. So collimation wise, we're in good shape. Exposure, pretty nice. We are able to see sharp differences between soft tissue and bone. The periosteum is well seen all the way through. You'll note that the medial clavicle right here has some superimposition with the lung and a couple of the ribs. Yeah, we're able to see good sharp edges, bony cortical, intermedullary spaces, etc. This is a nice picture. I'm assuming this was shot at 70 kVp at 8 to 10 mass, depending on their size. This is probably 8. Uh, yeah, very nice. You'll note on the AP that our medial clavicle is actually seen superimposed over the third rib right here. Okay, and that's where it needs to be. You can also see the superior angle of the or the scapula has some superposition with the clavicle. Clinically, our superior angle of the scapula should be even with the clavicle, so it's a little bit above it. But I'm convinced that it's some patients are a little bit different than others, and sometimes you'll get that evenness every time. Sometimes you're going to be a little bit above the clavicle, and that's okay. That's why we do an axial view. So, uh, marker, yeah, we've got a marker up here. It's a computer generated marker, which is okay, just as long as you know that that's a right and it's annotated correctly, which it is. But try to use your markers. It is okay to mark uh, post processing, but it's always nice to have your own marker on there. So, but there is a marker there. And like I said before, the name has been omitted for uh, we just not going to put anybody's name on there. So we can't really critique that. But this is what an AP clavicle should look like. Collimated nice and tight. We're able to see the entire clavicle and the joints. We're able to see the head of the humerus and a little bit of the lesser tubercle down here. We're able to see C5 superiorly. So yeah, it's a nice image, aesthetically nice. I would have no problem sending this image across. When I do look at images on one pack site, one thing that I've noted on clavicles is people are afraid that they're going to miss a clavicle, so their collimation is wide open. So when if you have that issue, just make sure your central ray, your X is, I mean, because you can feel somebody's clavicle. Just make sure your central ray is mid shaft of the clavicle right here, and then you can collimate, up and down. We don't need to go all the way down into their waist or all the way up into their face. It's just not necessary, and you actually get a better picture when you collimate a little bit tight. Just something to practice and work on. Get to where you can do a good clavicle. Doctors and patients will appreciate that. So let's go on to the AP axial. Okay, and this looks a little bit different. So positioning wise, we've got the sternoclavicular joint here medially. We're able to see the joint line right there. We've got the AC joint right here. We're able to see an open joint there. So we're not rotated at all. This is a very, very nice picture. The patient's back is securely against the image receptor or against the table, however you choose to shoot this image. Area wise, we're able to see the entire clavicle along with its articulations. So it's a nice picture. Collimation, we did pretty well. This one's a little bit more open than the AP. And note that we are using a 15 to 30 degree cephalic angle. We're still going to shoot for the mid clavicle area as far as a central ray. And you can keep the same collimation that you used for the AP. Just make sure that your central ray is where it needs to be, and you'll be good. Okay. So collimation wise, we're able to see what we need to see. We're a little bit open laterally and medially here. We only need to see to mid spine here. So we can catch that sternoclavicular joint, and we also just to the skin margin here. So we're a little bit open, which is okay. I just definitely wouldn't redo this image. Just takes practice to collimate a clavicle. So we can see C6 right here, possibly 7, I guess. So we're not all the way up to C5, which isn't the end of the world. We're able to see what we need to see here. You'll note that the clavicle right here is superimposed over rib number 1, which is what we need to be. So, and you'll note that the scapula, the superior border, is right here. Okay, so clinically, we need to have a 1/2 inch separation between the inferior border of the clavicle and the superior border of the scapula. So about a half an inch. So we're pretty close right there. You'll also note that uh, we've taken that clavicle and we've put it up above the scapula body. And we're just getting a better look at that clavicle. We have less superimposition with this picture, so it's a good picture for the docs to have. Exposure wise, yeah, we're again really good. Like I said before, the distinction between soft tissue and bone is very sharp. If there was any disruption in the cortical of the bone, we would be able to see that. So yeah, very nice. Again, we can see joint spaces in the spine. We can see ribs. We can see a lot of the scapula right here, the glenoid cavity, uh, and coming around the acromion process where it meets the clavicle. Uh, very nice picture exposure wise. I'm guessing we shot this 70 at 8. It's a good place to be for a normal sized person. So marker, yep, we got a right marker up there. Again, it's computer generated marker, which is okay. But try to get into the practice of using your actual markers. Uh, docs look at that, radiologists look at that. I know they're happy when there's a marker there, but when it's a placed marker, I think that they can trust the image a little bit more. Okay, it's annotated correctly. It's like that patient is looking at us. So yeah, very good job. So aesthetically pleasing, this axial is it's a nice picture. It's collimated a little bit open, uh, but again, definitely wouldn't uh, redo this one. And you'll note that we're seated a little bit low, so our clavicles should be right in this area right here. So when we our central ray was a little bit below the clavicle. That's the reason we can't see C5 up here. Okay. But so take a good look at these. This is what a clavicle series should look like. Um, get to know what should be there and shouldn't be there. If you're under collimating, practice on collimating. Just don't cut uh, anything off that we need to see. You'll note that when you do collimate a little bit tighter, your picture tends to look a little bit better, and that's just for the fact that there's less scatter radiation causing harassment with our image. So, collimation, it's a good thing. All right, well, thanks for coming by today. I'm sorry this was a little bit late this week. We had kind of a tough week, but next week, I'm not sure what we'll probably jump into the AC joints or something like that. But I appreciate you being there. I hope you're finding these helpful, and I hope you're digging into the radiology uh, stuff that I have on the hub. There's a lot of great information there, and it's important that we know this stuff so we're uh, giving the patient the best that we can. When we're submitting suboptimal images, sometimes diagnoses suffer a little bit. So take X-ray serious and practice. Read the material, watch the videos, get to the point where you're comfortable with what you're doing, and go sit for that exam. Get that license in your pocket. I'm of the opinion that you can't have too many uh, licenses, right? It just makes yourself more marketable. You're in a better position. So I'm here to help. Please give me a call if you need any help. But I appreciate you being here today. We'll see you next week, and you guys have a great week. See you.